interesting and beneficial. As we know, the calcified lesion in the PCI is a tool really challenging not only the young interventionist, but also the experienced interventionist, sometimes very difficult to solve. Calcified lesion makes the interventionist very difficult to expand the stent to deploy fully the stent under expansion or stent graft. Sometimes we met this session and for a long time a stent thrombosis. It's very terrible. So I think the topic today very interesting and very beneficial to hear the discussion, the lecture, opinion, comment from the expert from Vietnam and particularly from the US. I am Dr. Hồ Thượng Dũng, resident of Vietnam Society of Interventional Cardiology, Vice Director of Thống Nhất Hospital, Ho Chi Minh City, and I am co-chaired by Professor Trương Quang Bình.
Hello.
Professor Trương Quang Bình, the Vice Director of University Medical Center, Ho Chi Minh City, and another co-chair from America, Dr. Thạch Nguyễn. He is very close friend and big brother of all interventionists of Vietnam. Dr. Thạch Nguyễn, he is the Director of Cardiovascular Research Laboratory, Methodist Hospital, Maryville, USA. Academic Dean Tông Tạo University School of Medicine, Long An, Vietnam. And by now, I'd like to introduce the Vietnam faculty. The first, Professor Nguyễn Văn Tông, Director of Interventional Cardiology Department, Thống Nhất Hospital, Ho Chi Minh City. And the second, Dr. Nguyễn Thượng Nghĩa, Director of Interventional Cardiology Department of Chợ Rẫy Hospital, Ho Chi Minh City, Vietnam. And the third, Dr. Vũ Hoàng Vũ, Director of Interventional Cardiology Department, University Medical Center, Ho Chi Minh City, Vietnam. And last but not least, Dr. Đinh Đức Huy, Director of Cardiology, Chief of Interventional Cardiology Department from the Heart Hospital. By now, I'd like to introduce the faculty from America. Yes, the first of course, the co-chair with us, Dr. Thạch Nguyễn, and the second, Dr. Kwan Lee, Associate Professor, Department of Medicine, Associate Chief Division of Cardiology, Associate Program Director, Cardiovascular Director Fellowship, Cardiovascular Self-Healing from University Medical Center, South Tucson, Arizona. And the next, Dr. Rajesh Satyava, Professor of Medicine, Morehouse School of Medicine, Atlanta, Georgia. And the last but not the least, Dr. Gautam Kumar, Associate Professor of Medicine, Emory University School of Medicine, Atlanta, Georgia. And by now, your turn, Dr. Thạch Nguyễn, can you give some remarks briefly?
Thank you very much, and good morning, everybody. I would like to, I'm very delighted to be here today. The reason because this is an important and difficult topic in interventional cardiology. So from the US, we have a young team, energetic and overactive. And today, we will have a very interesting and active meeting today with the Vietnamese team. I'm sure the Vietnamese team also young, energetic, and very active. So thank you very much for the invitation, and we are looking forward for this interesting meeting. Thank you very much. I would like to introduce the first speaker, Dr. Kwan Lee. Dr. Kwan Lee is very special physician. I am very impressed. I am practicing in Indiana. I have maybe 4.5 star for the patient for the patient comments about physician. But Dr. Kwan Lee has 4.9 star in many more than 100 comments of patient. It's very special physician, very attentive, attending, and a very skillful interventional cardiologist. In Arizona or in Emory or in Atlanta, it's very competitive. It's not easy to be the star. In Indiana, we are people from the countryside, so we are laid back and we don't have any problem. But to be a star in Tucson, Arizona, to be a star in Emory like a Gautam and Rajesh, I feel very impressed with their action and their working skill. And this is why today, because it's a very active, difficult topic in intervention cardiology and new too. So this is why I invite a young team, energetic and very overactive. Thank you very much. And I would like to introduce the first speaker, Dr. Kwan Lee. He is right now Governor, Arizona Chapter, American College Cardiology. Dr. Kwan Lee will give us an overview about PCI in calcified lesion. Kwan, it's your turn now. Thank you.
Yes, thank you very much, Dr. Tak Wen, for that very, very kind introduction. Tucson, Arizona, I think is also the countryside, unlike Emory in Atlanta. That's a very big city. Yeah, it's a real honor and a pleasure to be back with you here in Vietnam. You know, last year we were at the SKY ASEAN Vietnam meeting, and I am sorry that this year that we are not able to be meeting in person again. Thank you, Professor Ho and Professor Trong, for this fantastic invitation on behalf of the Vietnamese Society of Cardiovascular Interventions, as well as all of my friends from Vietnam. As I said before, it's a real pleasure to be here. And it's also great to see my colleagues, my previous colleagues from Emory, Dr. Kumar and Dr. Sachdeva, who are extremely skilled and have done a lot of work in the world of coronary calcification. So I'm going to start sharing my screen here. Okay. So I've been asked to give an overview of PCI for calcified coronary lesions in the space of 15 minutes. And then I think from there, we're going to deal specifically with each of the subtopics. First of all, Dr. Kumar is going to talk about imaging and how to choose lesions to treat. And then we will have very specific left main calcification lesions. And then we're going to be talking about IBIS and OCT, as well as rotobladed, etc., in calcified lesions. So I'm going to start by just providing a basic overview to summarize the general plan of how we approach calcified lesions, as this is a very complicated topic. And, you know, for each of those subtopics, you can spend a long time, but we're trying to give you an overview here in the next 15 minutes. These are my disclosures. As Professor Ho mentioned earlier, coronary artery calcification is one of the highest and most difficult subsets of coronary intervention, and it presents challenges to the entire spectrum from junior attendings all the way to senior attendings. The picture on the left is based off an English saying that says where you are stuck between a rock and a hard place, as in it's a very difficult thing to deal with, and it requires a lot of skill and advanced procedural knowledge to be able to deal with this well. Give me a second here while I adjust my screen. So we have to ask ourselves first, what kind of special problems does coronary artery calcification pose when you try and perform PCI in these vessels? How do we identify who to use our special tools on? Do you just always use a rotoblader? That can't really happen either. What kind of tools are available, when and how to use them? And obviously, as you use all sorts of different tools, there are very specific complications that can occur, and we have to be also aware of those. This next 3 slides are from a paper by Maury H. From Alok Finn and Renu Vermani's group, and probably, in my opinion, presents the best summary of the histology and pathophysiology of coronary artery calcification, and that was published in JACC Cardiovascular Imaging in 2018. As you can see from the series of pictures here of radiography of autopsy studies of coronary arteries, the calcium can exist in many different forms. Not all calcium is created the same. Sometimes the calcium is speckled and in little small sections. Sometimes the calcium is fragmented, and sometimes the calcium is long and diffuse. And all of these specific patterns present different challenges when we're treating them. Generally, speckle calcification comes earlier on in the process of atherosclerosis, and it's not a later phenomenon and does not need to be modified. Here is a even more detailed picture from a micro CT of an autopsy specimen. And you can see here that on this side of the artery, there is a lot of calcium, but the calcium is in nodules dispersed throughout the tissue. And on the other side, you have sheets of calcium. And in general, sheets of calcium or larger gross nodules of calcium is the calcium that we're talking about when we talk about having to plaque modify before we proceed. This central illustration from that article gives you some idea as well as to the entire how calcium affects arteries in the lifespan of a patient. And you can see that calcium is present early on in acute unstable disease, but when it's present in unstable disease, it tends to be speckled, and so doesn't tend to really affect our ability to perform PCI as much. Really later on, as it goes from micro to punctate to fragmented to sheets, and then starts to form calcified nodules, this is once again the period when we have to start to modify our techniques to treat our patients with PCI. And it's only along this side of it that we also start to see it by either a fluoroscopy or by CT, OCT, or IBIS. And here is when the calcium score starts to rise. And it's important to also know from this that just because a calcium score is high on a CT scan, it does not always necessarily mean that the patient will require special techniques. So as was mentioned before, compared to non-calcified lesions, everything is worse. There's more post-PCI MI, there's more restenosis, there's more target lesion revascularization, there's more dissection during the procedures, ruptures and perforations. There's a higher rate of failure to deliver your stent. There's a higher rate of stent loss. There's a higher rate of balloon rupture, undilatable lesions, under expansion of your stent after you've deployed it with stent regret. And ultimately, all of this converge together to lead to a higher rate of stent thrombosis after PCI. So when we ask the question, how do we predict which calcified lesions may need special therapy with imaging? In some cases, some previous studies have just simply used angiography. They look at the angiogram, they see a lot of calcium, they say, okay, that's going to need modification. The problem with angiography, though, is that it occasionally underpredicts like who needs to be treated. Sometimes you look at the angiogram, it doesn't look to be very calcified. And then when you use advanced imaging, you start to realize that, you know what, it's going to be a lot more difficult than you think. And it often overpredicts who you need to treat. You know, I worked in a center when I first started, a small hospital in the countryside. For many years, I didn't have rotablator, etc. And even in heavily calcified lesions, we would still work and we would still get away with it often. And I'm sure many of you who have also worked without the special tools have found that a lot of times you can actually do your job without having problems. IBIS and OCT is actually ideal in helping you predict, but once again, access to IBIS and OCT and use tends to be lower. And some people argue sometimes that it over predicts. If you just use a single arc, so sometimes you find that there is one spot that has 270 degrees of calcium, but if you don't take into account how long or how deep that area is, you may actually not need to rotablate that lesion. And so the questions that you have to ask are exactly what measurements are you looking at? Is it just a calcium arc? Are you talking about superficial versus deep calcium? In OCT, unlike with IBIS, you can measure calcium depth. So the depth is important, and also the ultimate length of the area that you need to treat. One of the best tests to know whether you should treat something is simply also the failure to be able to pass wires, the IBIS scatter in itself. If the IBIS won't cross, then you pretty much know that you need to do something different, either that or balloon or stents. That's also a good marker of something is trying to tell you that you will need more advanced therapy. So what kind of strategic technical problems will occur in standard calcified coronary arteries? So sometimes, even though you don't have a significant lesion, if you have heavy calcification proximal to the lesion that you want to treat, you may have difficulty delivering equipment distally with an associated risk of stent stripping. So sometimes you still need to rotablate an area to be able to get your stent ultimately to the area that you want to treat. It may be difficult to cross the lesion with the wire because of the calcification. It may be possible to wire the lesion, but then not be able to cross with any devices. And then once you cross and you decide, okay, I'm going to go now, you still may not be possible to fully expand your stents. And that's called stent regret. And then once stent regret occurs, we have to be familiar with techniques of how to bail out and to finally expand the stent that you could not expand. To be able to deal with calcified arteries, you need to have a significant toolkit of equipment. And this includes your standard wires, your workhorse, your hydrophilic. Some people are proponents of the wiggle wire, especially when you don't have a lesion, but you cannot get the device down. And that's the wire that has little bends in it. And so as you push the device down, it doesn't get stuck on one specific spot. I think half the people that have access to it like it, half the people that access don't like it. I personally like it a lot. You need to know your rotor wires if you are a rotablator user, and then Viper wires if you're an orbital atherectomy user. You have to have access to guide extensions. You must have microcatheters for exchange, because rotor wires are not great wires to wire primarily. You tend to need to wire with a workhorse wire and then exchange with microcatheter. To be able to do that, if you have trapper balloons, that makes life a lot easier. If you have CTO balloons, when you're first able to cross, but then your regular balloons cannot get across, sometimes a CTO balloon will just let you get the tip in, and then you can start working that way. Ultra high pressure balloons are important. As you know, cutting balloons are a central device. Scoring balloons, and then obviously because of the risk of perforation, covered stents. And then ultimately also all the devices that you need to deal with perforations when they occur. These are the 4 calcium modification devices on top of what we've just talked about that are available to us in the United States and in Europe. I think in Vietnam, really it's just the rotablator. So, but still, I think it's useful for Vietnam to be aware of what's out there. The primary limitation is really cost. Cost is just simply too expensive. The lithotripsy balloon, which is a fantastic device for us to use, costs $5,000 US here for a single balloon. And if your balloon bursts as you are trying to advance it, or you try and advance it but it will not cross, that cost is still there. And it's just too much, I think, to realistically ask for. So besides the rotablator, you have the Orbital. The laser is probably the least useful of these 4 devices, but it definitely has its own niche applications. And then coronary lithotripsy, which has really been, just became available to us over the last several months in the United States, and has been a really helpful tool. So I'm just going to go over, in the last few minutes, several proposed algorithms of how to deal with this. And there are no right or wrong algorithms, and they're all slightly different from each other. But I think they all kind of, have the general principle is correct. Some people may disagree with specific parts of it, but I think they're worth reviewing quickly together. This first version is from Dr. Schlafmitz from St. Francis Hospital. He's a very heavy OCT user. And that is why in this algorithm, there is no mention of IBIS. So it says OCT and balloon uncrossable, okay? So he starts off by OCTing his calcified lesion. If the calcium is deep, he doesn't bother rotablating, etc. He simply performs a non-compliant balloon to make sure that it will expand, and then he stents it, and then he does a final OCT. If he does the OCT and the calcium is superficial, then he looks at the CVI score, which is developed by Akiko Mehara's group. And if the score is high, if its score is low, once again, they don't bother. They just do a cutting balloon or a scoring or a non-compliant. If the score is high, they then ask the question, is the balloon crossable? And if it's crossable, they do intravascular lithotripsy. If it's uncrossable, they then do rotational atherectomy or rotablator. Notice here, there's a special category for nodules. If they see a nodule, they don't, none of these other things are used. They have to debulk the nodule, and they go straight to rotational atherectomy or orbital atherectomy. And interestingly for this group, before they put the stent, they do another OCT to make sure that there's calcium fracture before they place the stent. So that's an interesting thing that I think a lot of people don't actually do. They do not repeat the OCT after this first rotational atherectomy run to make sure that there's fractures before they proceed. This next version, I think, is from his son because they have the same last name, Evan Schlafmitz from MedStar Hospital. So his algorithm is very similar, except that he does add IBIS. He recognizes, unlike his dad, that IBIS is useful to the thing. And otherwise, the algorithm is quite similar with pretty much the same thing, except that they recognize that you're using IBIS to say deep versus superficial. And then they use IBIS. I think obviously it's just IBIS arc, moderate to severe, and the rest of it is pretty much the same. Okay. And once again, they do repeat their OCT and IBIS after the initial treatment to make sure that there's fractures before they implant the stent. I think that might be unnecessary, but they swear by it. And will be great to hear from the panelists what they think about that. This is the version from Dr. McIntaggart from the National Health Service in Scotland. And their group has done a lot of work on this as well. And theirs is pretty similar for people with calcified nodules. They definitely recommend rotablator, etc. And once again, you know, they use, and that's the nodular calcium over here on this line, straight to rotablator if you see nodular calcium. Once again, if there is very heavy calcification, they do talk about the possibility of non-compliant balloon to start with if the angle is less than 180 degrees. And if it's greater than 180 degrees, they do not recommend going there first. They use rotablator or shockwave. And then they also image at the end to check before they place their stents. So quite similar, some slight differences. And then this is finally from Manny Brelakis, who I think many people have learned a lot about interventional cardiology from his YouTube series. He's famous for making these algorithms as well. And here, the difference between his algorithm, and this is his balloon undilatable lesion de novo. So this is when the wire crosses, but you know, the balloon will not cross. The balloon will cross, but then you know, he uses high pressure balloons first, then moves to angioscope cutting balloons or chocolate balloons, and then with the introduction of intravascular lithotripsy or high pressure balloons, he then introduces that idea here before performing atherectomy or orbital or rotational, only if that fails. And then finally, laser. This side of the thing is when that happens within the stent, i.e. with stent regret. And as you can see, calcium with stent regret on the inside, that is a different algorithm. They use high pressure balloon inflations first, and then they move to plaque modification. And then they go to intravascular lithotripsy. So intravascular lithotripsy has, I think, revolutionized the treatment of stent regret. It's a much better way of treating than the traditional way in the past, where we use laser bombing. or we would actually rotablate the stent sometimes, to be able to achieve this, and which is clearly not a great idea. And so, yeah, those are the primary differences. So there are, besides that, all the algorithms that we showed you, there are clearly also very special PCI situations, and that's beyond the scope of this talk, but we need to be aware of those, and those will be osteo lesions. How do you use, how do you treat bifurcation lesions when they're heavily calcified? Chronic total occlusions with the possibility of subintimal dissection around the CTO section and re-entering distal to that. How do we treat calcified nodules? We talked about that. And then also the complexity of treating calcified disease in STEMI and cardiogenic shock, as well as saphenous vein grafts. All those are even more specialized. So to conclude, so that we can listen to the rest of our experts, PCI and calcified coronary arteries can be one of the most challenging subgroups of coronary intervention. Many technical skills are required to perform successfully, and you need familiarity with a wide variety of specialized equipment. There are several well-described strategic algorithms to manage these. But we should argue that in Vietnam, for example, because of the special availability of only some of the tools, that maybe, or maybe this could be a publication from the Society, Vietnamese Society of Cardiovascular Intervention, that there should be a local algorithm developed, as not all equipment is available. The next frontier is all of those algorithms really talk about using the devices as single devices, but how or when should we use the devices in combination? And Dr. Kumar is an expert at this, and he has published his RotaShock series, where they rotablate and then they perform shockwave on top of that. Obviously, for most places, that is very expensive proposition. There has been literature out there in trials where they just did rotablator and then they did cutting balloon before they finally implant their stent. So how do we use these devices in combination, and when should we? And with that, I would like to thank you. We hope to meet in person soon. And these are several pictures I took a few weeks ago from the Albuquerque International Balloon Fiesta. Thank you very much.
Thank you, Dr. Kwan Lee. I think that this is a very general, very interesting presentation about the way we manage the calcified lesion for PCI. You give us the general information to do PCI successfully. Especially, you give us 3 points. First, we need the devices for assessment the calcified lesion. The second, to prepare enough the device for intervention, for example, guiding, guide wire, balloon, and maybe rotaplator to do PCI. And the third, the final, you give us at least 3 algorithms in PCI for calcification lesion. I think this is very useful for us, for interventionists to do the PCI for the calcified lesions. And now we go to the discussion part. First of all, I would like to invite Dr. Nguyễn Văn Tân. Do you have any comment on the device to assess the calcified lesion? Dr. Tân, please.
Yes. Thank you very much for your introduction, Professor Trương Quang Binh. And thank you very much for your presentation, Dr. Kwan Lee. Very interesting and very overview presentation. I think in the Vietnam now, we have only rotaplator for management for calcification. So I hope in the future we have more device to treat the heavy calcified lesion in the future. For example, lithotripsy or another one. I would like to give some opinion. So now we in the USA we continue to the PCI with algorithm, local algorithm. So I don't know exactly in Vietnam now. So I hope in the future Vietnam society intervention, also a society can give algorithm for continue to PCI heavy with heavy calcification. Thank you. Yes.
Thank you, Professor Nguyễn Văn Tân. And I would like to invite Professor Thật Nguyễn. Do you have any comment on the presentation of Dr. Kwan Lee?
Thank you very much. I learned a lot from the talk of Professor Kwan Lee, but I would like to leave the time space for the young intervention cardiologists. I have my ideas about calcification in the arteries because one simple thing, after we put a stent in the arteries, the flow is similar to a very calcified artery. So this is why we shave the calcium to put a stent. In hydraulic, it's the same thing as we put another segment of the artery full with calcium, rigid and hard. So this is only my comment. Thank you very much.
Thank you, Professor Thật Nguyễn. Dr. Vũ Quang Vũ, do you have any comment about the tool, the device for assessment of the calcified lesion? How about in your center?
Thank you, Professor Bình. Thank you, Kwan Lee, for the good presentation about the calcified coronary lesions. In my center, we use only IBIS. We don't have the OCT in the cath lab, so only use IBIS. And the IBIS we cannot see the thick of the calcium, so that's a problem with the IBIS. So we only do the IBIS and we see what happened with the vessel. But now normally when we see the angiogram, if we have the mild calcification, I think the lesion can be dilated with the NC balloon or scoring balloon or something like that. I think it's enough for the plaque modification before the stenting. If the angiography we have some moderate or severe calcification, we try to do some rotablation or something like that. And Kwan Lee, can you share with us some experience about the how to choose the rotablation, rotational atherectomy, or little gypsy or orbital atherectomy? Some your experience about that, how to choose the device when we have some imaging, we have some angiography. Thank you.
Thank you, Dr. Vũ Quang Vũ. I will have one question for Dr. Kwan Lee. In my center, we just have the IBIS only. Do you think that we need to have OCT equipment to assess the calcified lesion for intervention?
That's a great question. You know, OCT obviously provides much better volumetric assessment because the pullback is always very accurate. You know, unlike IBIS where the pullback is very rough and you just see one picture. And IBIS sometimes jumps a lot, especially in calcified lesions. As you pull back, it doesn't come back in a uniform fashion, so it tends to jump. And then sometimes you miss something because the IBIS probe went too fast as it got stuck on something and you're pulling and then suddenly it comes back. I find in those situations, it's better to push the IBIS forward, not pull back, to be able to see sometimes because otherwise you miss things. I don't think, to be honest with you, that even though OCT has better depth imaging and thickness ability, that you need OCT to really. There's never been a trial that has evaluated the ability of either OCT or IBIS to accurately predict. And one of the most powerful ways of knowing whether you may have a problem is also the simple inability to push the IBIS probe down. You wired the lesion, you try and push the IBIS and it won't go. You need to rotablate that. So that's also a very helpful finding. while the OCT because it's smaller, it tends to be able to go further and it doesn't alert you that way as well. So I think when it comes to cost, etc., I think you can just do it with IBIS. It is good enough.
Yes. Professor Hồ Tường Dũng, I know that in your center you have two systems, one the IBIS system and second the OCT system. When you use IBIS, when we use the OCT for assessment of the calcified lesion.
Thank you, Professor Chung Quang Bình, for your question. I agree with Dr. Kwan Lee. When we can record from OCT, the resolution of the OCT very excellent. So we can see, we can evaluate, assess the calcified lesion very clearly. But I think in the case very calcified lesion, long and diffuse, because the catheter of the OCT very delicate, we cannot advance across the lesion. But in the catheter of the IBIS, I think it's strong because it's over the wire, strong. And so, and another reason, you like to record the good image of OCT, you must evacuate the blood. But in the severe and long lesion of diffuse calcified, we cannot evacuate the blood. And sometimes we try to push to the distal of the calcified lesion, but when we record, we can see anything because, yeah, I think so. But so in my center, we have two tools, and if I think that the calcified lesion not very stenotic, we use the OCT. It's very clear and it can give them many information. But in the very difficult case, we often use IBIS.
Thank you, Professor Hồ Tường Dũng. Now it's time to go to the second speaker. It's Professor Gautam Kumar. He's the Associate Professor of Medicine in Emory University School of Medicine in Atlanta, USA. He will give us the topic, Seeing the Plaster and Concrete on the Wall, Imaging for Calcified Lesion. Yes, I would like to invite Dr. Gautam Kumar.
You are on mute.
Hello, are you able to hear me?
Yes, I hear you clearly. Okay,
excellent. Good morning. My name is Gautam Kumar from Atlanta, Georgia. First of all, I would like to thank Professor Ho, Professor Trong, Dr. Wen, and for kindly inviting me for this meeting. Of course, Tak and I have been good friends for a long time, and I would like to thank Tak for coordinating this and for inviting us as well. And it is very good to see my old friends, Dr. Wu and Dr. Hui on this as well. And it has been a long time since we have met, I think maybe in Malaysia live a few years ago and then Singapore live, but it will be good to meet again when we are finally having meetings in person again. So, well, I have no disclosures that pertain to this topic. So this is the outline of my talk. I'm going to be telling you about a visual analogy. We'll talk briefly about overview of different imaging options. Something that's close to us, angiographic assessment of calcium. Then we'll talk about intravascular imaging with the intravascular ultrasound, OCT, and perhaps I will be able to grace the surface on IBIS versus OCT for calcified lesions. And then we'll talk about a case, and then we will conclude. So this is a nice house, and we recently renovated this house, and you can see this beautiful brick wall that you can see on the right side. Very nice brick wall that makes it look like it's like an old factory kind of look with painted over brick, post-industrial era type appearance. But my question to you is that brick wall real? And no, the answer is that brick wall is not real. It is actually just a veneer of brick put on wooden plasterboard. So you see, it is important to be able to see through the plaster and the concrete inside the walls to understand what is actually in those walls and not just look at the lumen, okay? So there are multiple imaging options for coronary calcification, and we will start with non-invasive imaging options. You can detect coronary artery calcification by CT. This is an excellent technique for detecting calcium. Unfortunately, it might not have a whole lot of meaning for us because there's not been much correlation between calcium on CT and need for atherectomy. It can localize the coronary artery calcium, and it can also quantify the coronary artery calcium. You've all heard of Agatston scores that can quantify coronary artery calcium, but this is not the whole artery calcium score that you're given. It is actually a per vessel calcium score that you have to calculate, which may be sometimes helpful to predict what's going on. Coronary angiography can't be great in terms of detecting coronary calcium, but if you do detect calcium on coronary angiography, it is likely to be severe. It can localize the calcium, and it can also quantify the calcium plus minus, not really that good. IBIS is fantastic for detecting coronary calcification. You can also localize the calcium and to a certain extent quantify it. With virtual histology, you can identify the tissue composition in addition to the calcium, and you can tell what is going on there in the tissue as well. Finally, with OCT, you can identify the sharp delineation of the calcified area. You can identify the calcium extremely well, and you can see that localization of calcium is also excellent. So let's talk briefly about angiographic assessment of calcium. This can be classified in this very classic paper by both Mintz and Tusu from 95 and 96 that really hasn't changed a whole lot since then. You can classify it as none or mild, moderate where you have radio opacities which are noted during the cardiac cycle before contrast injection, and severe where radio opacities are noted without cardiac motion before contrast injection, but it compromises both sides of the vessel lumen. And when you compare this definition with IBIS, the sensitivity is about 50% of angiography, both according to the Mintz article and the Tusu article. And in the Mintz article, severe calcification by angiography had an arc of at least 238 degrees. The definition that was used for severe calcification in the more contemporary era, which is the Orbit 2 definition in the Orbit 2 trial for orbital atherectomy, was an arc of 270 degrees. And that reflects transition from the era of angiographic assessment to intravascular imaging. So the calcium is definitely out there. This is from the survey of angiograms done in the United States. The calcified lesions, we are averaging about 30%, maybe higher calcified lesions. So the calcium is definitely out there. Even in ACS lesions, this is pooled data from almost 7,000 patients from Acuity and Horizons AMI. And you can see that as the amount of calcification increases, as Dr. Lee alluded to earlier, not just the procedural complications go up, but also eventual risk of death, cardiac death, MI, TLR, and MACE also start to go up as well. So that, becomes a very important thing to appreciate. So in terms of intravascular imaging, we can look at IBIS, which is on the left, A, B, and C, and OCT, which is on the right, which is D, E, and F. And you can see here that the arc of calcium is being identified. In the first image, there is very mild amount of calcification. With moderate calcium, it is about 180 degrees of calcium in both these images, and you can see it both on IBIS and OCT. With severe calcification, you can see an almost 360-degree arc of calcium. In addition, now the last two images, C and F, I would like to draw your attention to. And if you're able to see my pointer, you can actually see here that at this point, this is the leading edge of the calcium, and this is then followed by an acoustic shadow. Now, on the OCT, it is able to penetrate through this, and you are able to assess the thickness of the calcium. And this is something that Professor Ho alluded to a few minutes ago as well. In terms of the IBIS assessment of calcium, you can look at this, and these are details from this paper. This can be classified, it looked at a huge number of lesions, and about 300 of them had moderate calcium, 130 of them severe calcification, and a large number of them had target lesion calcium. So in general, we tend to think about these calcifications as the arc of calcium, the length of the calcium. Now, length can be a little tricky if you're doing manual pullback on your intravascular ultrasound. However, length can be easy to assess if you're using a pullback sled with the Boston device, for example. The distribution of calcium is an important thing, superficial versus deep, lesion associated versus reference. So that's also important because that's going to tell you what you're going to do. And as Dr. Lee alluded to earlier, you may have a lesion that is not very heavily calcified, but you may have a heavily calcified proximal segment that may cause you trouble in delivering devices to the target lesion, which can cause problems as well. And finally, it's important to understand whether the thickest calcium or the area where you have calcification is concordant or discordant with the plaque thickness. And IBIS can tell you this as well. The importance of this is that if you have calcium that is opposite to where the worst plaque is, this may not be very well ablated by the rotational atherectomy device because of the discordance between the discordance between the compliance of the two areas. So there are some issues there as well. In terms of the OCT assessment of calcium, we can think about multiple things, and this is a scoring system that Dr. Lee again alluded to earlier. You have the maximum calcium angle, whether it is less than 180 degrees, you get 0 points, more than 180 degrees, you have 2 points, maximum calcium thickness, less than or equal to 0.5 millimeters, 0 points, more than 0.5 millimeters, 1 point, calcium length, less than or equal to 5 millimeters, 0 points, greater than 5 millimeters, 1 point. And if you score the higher on this, the worse you're going to get. And let's examine this. They looked at a test cohort of 969 patients, and it ultimately came down to 128 patients with a calcified lesion with whom they validated this algorithm. And then they looked at a validated cohort with another 133 patients with a calcified lesion. And these 133 patients, as the thickness of calcium, if it was greater than 0.5 millimeters, stent expansion was less than 70% in 10%. Now, if you think about it, stent expansion less than 70%, 10% is not that bad. But on the other side, when the thickness of calcium wasn't high, it was 0%. And again, when the calcified segment was long, which was in 57 patients, stent expansion again was less than 70% in 17%. Again, on the other side, when it's less than 5 millimeters, stent expansion less than 70% was not there at all. Finally, if you look at the angle, if it is greater than 180 degrees of calcification, again, about 30% of these patients had inadequate stent expansion, whereas if the angle was less, then you had a better result. And this is actually an image that shows you some of these issues, where you can see that if you have minimal calcification, you have very good stent expansion, you have a nice round stent that we like to see. But if the moment you start having worse calcification, you have a longer arc of calcium, even you start seeing that with the calcium scoring system that we talked about here of 4 points, you see that stent expansion goes down to 68%. So it's important to realize that with OCT, you can actually really quantify and assess the calcium. So what about IBIS versus OCT? This may be of interest to Dr. Lee. The sensitivity and specificity of angiography to detect OCT calcium, any OCT calcium, was 50%. And the sensitivity of angiography to detect IBIS calcium was also around 50%. So yes, they lined up pretty well in that regard. All cases with OCT detected calcium were also detected by intravascular ultrasound. Good news. 4 angiographically detected calcification cases were actually missed by OCT. And believe it or not, gentlemen, 1 was missed by both OCT and IBIS. So sometimes calcium can be missed by both as well. So that I thought was interesting. But the good news is IBIS and OCT appear to be pretty interchangeable because the OCT and IBIS calcium angles were pretty similar. And they were really only different by less than 10 degrees, which is not clinically significant. Now, OCT can often be used to measure calcium thickness, but it is important to realize that when you have superficial and deep calcium in the same area, like you're looking over here, this asterisk marked line is actually here, and there's a calcified area below it, but here you can't tell the depth of the thickness of this calcium at all because of the calcified area below it. So there are scenarios where deep calcium can be missed if there is superficial calcium, even by OCT. So finally, I would like to give you a little comparison of IBIS and OCT for calcified lesions. The presence of calcification can be identified both by IBIS and OCT just as well. The arc of calcium can be marked by either technique just as well. The type of calcification, IBIS and OCT can often be used to identify whether it is superficial or deep. OCT tends to be a little better in identifying it. IBIS, if you have calcium, sometimes it can be hard to tell because of the acoustic shadowing. Length of calcium on IBIS, yes, you can identify if you use an automatic pullback sled or you use co-registration. On OCT, yes, the length you can always identify it. Thickness of calcium on IBIS, usually no tell because of the leading edge will cause an acoustic shadow. With OCT, usually you can tell. More often than not, you can easily tell the thickness of the calcium. With IBIS, contrast use is not required. This is an important thing to note, especially in renal failure patients. With OCT, contrast use is definitely required. And I bring up renal failure patients because these are, again, the same patients who have kidney disease, who also have significant calcification in their arteries as well. So unfortunately, that kind of travels together, and it's important to mitigate contrast use on these patients to prevent CI-AKI. In terms of aorto-ostial lesions, IBIS can work out very well. With OCT, sometimes it tends to be okay. You may need to use an adjunctive guide extension catheter or other techniques to optimize the image, but IBIS is a lot more reliable in this scenario. Now let's look at a case. This is a 69-year-old male who was referred for cardiac evaluation for carotid and atherectomy. He had no angina, he is sedentary. He had a stress test that showed a 15% defect. He has diabetes, hypertension, hyperlipidemia, and is a current smoker. So all of these are calcium risk factors for having calcification in the coronaries. And this is his coronary angiogram. I would like to play through that and maybe ask the panel or anybody, actually, a couple of opinions on how many of you would, we'll let that play for a second, and you can see that there is that LAD lesion. Would you want to do balloon and stent it? Would you do a FFR? Would you do an IBIS? Would you do an OCT? Or would you do, you decide to do a atherectomy with balloon and stenting? Can we maybe get some opinions if you have a second?
I think we make the IBIS before the pre-PCI for the MID because very important, because only the total occlusion of the left surf and you see the hazy of the, when you do angiogram, we see a hazy in LED. Maybe it is the calcified, moderate calcification in the LED. So I think you need to do the IBIS before we do the PCI in this case. In my opinion only. And Dr. Nghĩa from Jarai Hospital, yes.
Gautam, I would probably do an IFR with co-registration just to understand which areas need to be treated, because it's quite diffuse and it's possible that,
yes.
yeah, that you might need to treat more than the just focal areas, and then IBIS it to understand the calcium, etc. And then based on the IBIS, decide if I need to rotational atherectomy before PCI.
Yeah.
Okay. All right. So everybody says we have to do FFR. So here is your FFR.
IFR.
FFR was 0.75. The back of it from the blue line onwards is the pullback. And that was basically from around here to here. It's where you get this drop. It was a pretty quick pullback. And so then we decided, I will show you the angiogram one more time. And again, angiographically, you know, I can't say I was terribly impressed by the amount of calcium, but there is some there. And so then we did intravascular ultrasound with the poor man's co-registration. And you will see this is my co-registration image for you.
Yeah.
And there are areas with severe calcification, mild calcification, severe calcification again, moderate calcification, and no calcification with a relatively clean disease segment. So in this case, you know, we elected to perform atherectomy since there were areas of severe calcification that we wanted to maximize our stent expansion. And we decided to do orbital atherectomy in this case with Diamondback. And we did 80,000 RPM with 4 passes in the more proximal part of the lesion, and subsequently in the more distal part of the lesion, so total 8 passes. And subsequently, we then used a specialty balloon to balloon it, and then deployed a stent in this 2 stents actually. It was actually a longer lesion, and so we had to put 2 stents. And I tend to post-dilate these pretty much empirically, and so we post-dilated it nicely. And this is our final result with MSA of 8.5 in the proximal LAD and 4.2 more distally in the mid LAD. So in conclusion, angiographically inapparent calcification is a real issue, like in this case, that can affect PCI success. It is essential to rely not just on a luminogram and look at the plaster and concrete in the walls. OCT or IBIS imaging is essential in these cases to optimize PCI results. Thank you very much.
Thank you, Gautam, for an excellent lecture for of imaging IBIS or OCT for calcified lesions. I think based on what you presented, we know that not only the angiogram can give us the details of lesions, but with IBIS and OCT, we can look more clearly, and then the operators can have a better idea to how to treat the lesions. So can you share us some experience of do you believe that if we have imaging guided PCI, then it will translate to better outcomes of patients after PCI, even in stable angina or in acute coronary syndrome?
So yes, the strategy of IBIS guided PCI has been studied in the ultimate trial that you're familiar with outside the United States, and that has been shown. We are awaiting the results of the Illumian 4 study for OCT, which we will have a better perspective on OCT guided PCI. Now there is also ongoing US trial, which is known as the IMPROVE trial, which is again IBIS guided PCI versus angiographic guided PCI. I do personally believe that imaging guided PCI tends to produce better outcomes, even for non-calcified lesions, but definitely in calcified and complex PCI lesions, left mains. These are all lesions that you should probably definitely use imaging. To actually make things more cost efficient, I think it is definitely important to consider imaging in the more complex lesions that you're doing, not necessarily in the simple type 8 lesions where you're able to put one stent and call it a day. So I think that's probably how we can use these tools and optimize PCI.
Thank you. Dr. Rajesh, how about your opinion of applying imaging in routine daily practice? In Asia, Japan is a country that's IBIS, I think, very often in PCI. In some of like the stopped up clinical trial from Japanese doctors, nearly 100% of PCI procedure was guided by IBIS or OCT. How about it in US or especially in your center?
So we are very heavy on using intravascular ultrasound and OCT in our PCIs. I think in the US, penetration of IBIS and OCT, I think back in 2010 was somewhere in the range of 9 or 10%. I think that number has probably gone around maybe 18 or 19% now. I think there has to be, we have to do better. I think imaging definitely improves outcomes. Imaging gives you things you probably don't sort of think. And on top of that, I want to throw is that you can do a post-stent FFR. If you've done a pre-stent FFR and you've treated the lesion, you can do even a post-stent FFR, and that can also predict your outcomes. There is value to all these technologies which are there. Now, cost is a big issue, and I can understand in Vietnam how this can be applied, as Dr. Kumar said. I think the best sort of return for this cost would be to use this technology in patients who have a complex disease, where you will have, I think, the best utility of this technology to help you improve outcomes.
Yes.
Thank you. Dr. Nghĩa,
I would like
in Chennai Hospital.
Yeah, I have one question for the Dr. Kumar. Yeah. Dr. Kumar, I have asked you one question. When because you present your presentation very interesting. When you compare with the OCT and IBIS, when you do the PCI, which is the tool you prefer to use in the in PCI in your cath lab or in US? Yeah, because in my cath lab I only use the IBIS only. Yes.
Thank you very much for that great question. So I believe that it should be individualized to the patient that you are dealing with. If I have a patient who has chronic kidney disease, and we have a creatinine of say 1.4, 1.52, or then in that patient, I think OCT is probably not a good idea, because you want to minimize contrast usage for that patient. That is the patient that I would consider doing intravascular ultrasound in. Now, we have been experimenting and doing some things without giving any contrast, but those things that remains in the realm of research and investigation practice. I say we tend to use would also typically go ahead to look at stent expansion and apposition as well.
Yeah. Okay. Thank you, sir. Because yes, because in I think in US you had a high resolution the IBIS. So if compared with the OCT, high resolution IBIS is the same quality and same for you quantity, the calcified plaque when we do the PCI.
So if for the purposes of calcified plaque, I think for those purposes, I think OCT is still probably better. We have limited experience with high resolution IBIS. Most of the time we tend to use the 20 Hertz eagle eye platinum catheter. We have some experience with rotational IBIS that we have used, and it does provide better resolution, but I don't feel like it makes that jump to the level of resolution of OCT. And if you look at the resolution, OCT's resolution compared to high resolution IBIS, even with the really high 45 megahertz catheters, is actually still better with OCT, and it's an order of magnitude of around 10-fold. So I think at this point in time, if you're looking at resolution alone, OCT is probably the best. But if you're looking at both practical use, if you're thinking about speed, if you're thinking about minimizing contrast usage, I think regular IBIS catheter, not even HD IBIS, but just regular IBIS is probably adequate. If you have HD IBIS, that would be fine.
Yeah, thank you. Thank you, sir.
Thank you, Gautam. Thank you, Dr. Rajesh, for discussion in this topic. So I think we are 10 minutes behind of the program. So let me introduce the next speaker. So the next speaker will be Professor Hồ Tuấn Dũng, the president of Vietnamese Interventional Cardiology. So his topic will be the optimal PCI for left main calcified lesions. So Professor Dũng, please share your screen.
Okay, thank you so much for your presentation, Dr. Đinh Đức Huy.